Good afternoon. I've been invited to present on the topic of lung and diaphragm protective ventilation. My name is Ewan Goligher. I'm from the University of Toronto. These are my disclosures, including support in the form of equipment from Tim Pell and Gettinga and personal fees from Gettinga in the past 2 years. So many of you will be already familiar with the concept of ventilator-induced diaphragm dysfunction, the idea that being on the mechanical ventilator actually leads to acute diaphragm atrophy and injury. And this was classically described by Knisley and colleagues in the 1980s. And since then, there's been an abundance of clinical observation to support the recognition that this is an important clinical entity, an important clinical problem. So for example, several years ago, we published this work showing that diaphragm thickness changes rapidly during mechanical ventilation. And in a substantial subset of mechanically ventilated patients, we observed a rapid early decline in diaphragm thickness, the group shown here in red, constituting about 45% of patients. Another small subset of patients developed a rapid early increase in thickness, raising the hypothesis of possible load-induced injury. And interestingly, both of these changes in thickness, both decreases from baseline and increases from baseline, were associated with a lower probability of being liberated from mechanical ventilation on any given day, suggesting that these changes in thickness represented clinically important deleterious changes in muscle structure. So changes in the diaphragm, which we refer to as diaphragm myotrauma, are associated with delayed liberation from mechanical ventilation. And the question becomes, can these changes in the diaphragm during ventilation be prevented? Well, several different mechanisms have been postulated for acute diaphragm atrophy and injury during mechanical ventilation, including what we call over-assistance myotrauma, where the diaphragm activity is suppressed because of excessive ventilatory assistance. Alternatively, under-assistance myotrauma, where because of inadequate unloading of the respiratory muscles, the muscle is subject to load-induced injury. Eccentric injury, where the muscle is forced to contract eccentrically or as it's lengthening. And also possible expiratory myotrauma, where maintaining the muscle at a shortened length for a period of time results in acute sarcomere dropout. So several different mechanisms have been suggested, and it's possible that by attending to these mechanisms, we might actually be able to modify the risk of diaphragm atrophy and injury and thereby improve outcome. So for example, the rate of change in diaphragm thickness over time is associated with the level of respiratory effort. This figure shows the change in diaphragm thickness over time, modeled as a function of time on the x-axis, and diaphragm contractile activity measured by ultrasound on the z-axis, on the y-axis. And you can see that when diaphragm contractile activity measured by the thickening fraction is very low, that was associated with a rapid decrease in thickness, whereas when contractile activity was very high, it was associated with a rapid increase in thickness, which we hypothesize constitutes load-induced injury for various reasons. And this suggests that the level of respiratory effort, the level of diaphragm activity, is a key determinant of the risk of developing these clinically important structural changes. And accordingly, the level of diaphragm activity measured by ultrasound was also associated with patient outcome. So if both insufficient or excessive levels of diaphragm activity are associated with diaphragm injury or atrophy, you would also expect both insufficient or excessive levels of diaphragm activity to be associated with prolonged ventilation. And that's exactly what we found in our data, suggesting that possibly by targeting an intermediate level of respiratory effort consistent with healthy subjects breathing at rest, that we might avoid diaphragm atrophy and injury and improve outcomes for patients. So this leads to a concept that we refer to as the myotrauma pathway, where inappropriately applied mechanical ventilation results in excessive or insufficient inspiratory effort, which then leads to diaphragm injury and atrophy, and consequently results in prolonged ventilator dependence. And using a technique called mediation analysis, we were able to show that intermediate steps in this pathway account for the relationship between ventilator settings and diaphragm injury, and that the changes in diaphragm thickness account for the relationship between inspiratory effort and prolonged ventilation. So this supports, but doesn't confirm, the existence of a causal pathway connecting the way we set the ventilator to the patient's risk of prolonged ventilator dependence. And of course, prolonged ventilator dependence is an important outcome because patients who remain on the ventilator for a prolonged period of time are at very high risk of long-term functional disability and death. So by intervening on the way we set the ventilator, potentially we might be able to modify this pathway and improve outcomes for patients. Of course, respiratory effort is not only important with respect to the diaphragm, it's also increasingly recognized to be important with respect to the lung. And when the respiratory muscles contract vigorously, they increase the volume and pressure applied to the lungs. So the transpulmonary pressure, the lung distending pressure, is the mathematical difference between the pressure in the airways and the pressure in the pleural space. So when the respiratory muscles are contracting vigorously, pleural pressure becomes very negative, and for a variety of reasons that can lead to lung injury. So for example, even when airway pressures are relatively low, as shown here in these tracings, because of vigorous respiratory efforts, as shown by the esophageal pressure tracing, the transpulmonary pressure swings are very, very high and almost certainly injurious. So we want to avoid respiratory effort being excessive from the standpoint of lung protection. So all of these concerns, modulating respiratory effort to protect the diaphragm, modulating respiratory effort to protect the lung, leads to the integrated concept of lung and diaphragm protective ventilation. So where conventionally we focus on lung protective ventilation, now recognizing that the way we set the ventilator can have an impact on the diaphragm, we need to be concerned both for the lung and the diaphragm as we're setting the ventilator. And this is a complicated problem, and this is the real message of this figure I'm presenting here. This figure is from a forthcoming paper in the Blue Journal where we outline these concepts in some detail. But it's a complicated problem where we have many, many competing considerations at the same time, where insufficient ventilator assistance might be injurious and excessive ventilatory assistance may be injurious, but a whole other range of factors, including sedation, patient ventilator synchrony, the level of PEEP, can all have an impact on the risk of lung and diaphragm injury. And all of this, of course, is modulated by the patient's own characteristics and biological predisposition to injury to the lung or the diaphragm. The basic concept of lung and diaphragm protective ventilation is that we shift mechanical ventilation from being a two-dimensional problem to a three-dimensional problem. So the two usual dimensions we're concerned about when setting the ventilator are first, respiratory homeostasis, that is maintaining adequate CO2 clearance through the lung, and secondly, lung protection, so avoiding volume trauma, anaphylactic trauma, et cetera. We want to minimize cyclic lung stress by using low tidal volume ventilation. And so these are the two dimensions that we normally are concerned about. We're proposing to add a third dimension to this, and that is diaphragm protection. And this is achieved by, along with maintaining adequate respiratory homeostasis and along with protecting the lung, we're targeting a modest respiratory effort level to avoid both load-induced injury and diaphragm atrophy and maintain patient ventilator synchrony. And the vision is that by adding this third dimension, we can further improve outcomes. We can, by attending to respiratory drive and effort, recognize and relieve dyspnea, which is an important clinical problem in respiratory failure. We can potentially accelerate liberation to prevent nosocomial complications and the development of ICU-acquired weakness, potentially reduce the long-term risk of death, and improve long-term functional status and quality of life. Essential to this undertaking, to doing lung and diaphragm protective ventilation, is improved and targeted respiratory monitoring. And in particular, because optimizing respiratory effort is central to this project, we need to begin monitoring respiratory effort. And there's a range of ways of doing this available to us already. The gold standard techniques are techniques such as esophageal manometry or diaphragm electrical activity. But even when those techniques are not available, we can use non-invasive measures, including the airway occlusion pressure, or P01, which is a measure of respiratory drive, and what we call the expiratory occlusion pressure, or POCC, which is obtained by a simple end expiratory occlusion during assisted ventilation. These pressure swings shown here on the figure on the airway pressure tracing provide an assessment of the magnitude of the patient's respiratory effort. And so by performing these maneuvers on a regular basis, we begin to detect when respiratory effort is absent or when it's excessive. And this allows us to titrate to the appropriate level of respiratory effort. So monitoring is essential, and it turns out to be relatively straightforward to assess respiratory effort with these simple techniques. So in this position statement that we published in the blue, I want to just represent three of the key statements on which there is a high level of consensus amongst panelists participating in the conference. This was an expert conference organized by the Pleural Pressure Working Group of the ISICEM over a year ago, and we had over 30 panelists who rated various position statements after our meeting. And I think these three deserve to be highlighted. First of all, there is a high level of consensus that respiratory effort should be assessed routinely during mechanical ventilation as part of the risk assessment for lung and diaphragm injury. In 2020, it's very difficult to say that you've adequately assessed the risk of a lung injury or diaphragm injury if you're not continuously monitoring or regularly monitoring respiratory effort. Secondly, from the standpoint of diaphragm protection, given the complexity, given the many competing mechanisms at play, this really requires clinical wisdom and clinical expertise and a careful clinical assessment. And we want to push back on the notion that you can do recipe-based mechanical ventilation. There's no single universally applicable one-size-fits-all setting for optimal mechanical ventilation. We had 100% agreement about that amongst panelists. And then with respect to the issue of the fact that the lung and the diaphragm protective efforts may actually compete against each other, maintaining respiratory effort to protect the diaphragm may increase the risk of lung injury. Given currently available evidence, protecting the lung should be prioritized over protecting the diaphragm when necessary. And so these are just some of the key statements outlined in this paper. So I want to summarize, wrap up by giving an integrated picture. So mechanical ventilation is traditionally targeted at maintaining adequate homeostasis, at avoiding volume trauma, and we're proposing that the ventilator should be applied with the goal of avoiding myotrauma as well, because this also has an impact on clinical outcomes. And in order to do that, we need to apply lung protective ventilation and diaphragm protective ventilation strategies, and ideally integrate them together. And in order to do that, because monitoring respiratory effort and optimizing respiratory effort is key to this goal, we need to consider how the role of sedation and its impact on respiratory drive and effort, as well as the potential role of extracorporeal life support to enable us to fine-tune respiratory drive and effort in order to achieve lung and diaphragm protective ventilation goals. Thank you very much.